Peter Block in Orlando at the AHA annual meeting for On the Scene, and with me is Paul Richter. Paul is from the Brigham in Boston, and he and I have had a number of these interviews about the Jupiter trial. Paul has taken another look at some of the data from Jupiter, this time having to do with percent reduction rather than absolute levels of what LDL should be. So, Paul, tell me about what you did with the data, and then we'll talk about what this actually means clinically, because it is important.
Well, sure, Peter. As you know, there's been a lot of controversy about guidelines and whether we should have targets or not. And interestingly enough, our European and Canadian colleagues have gone with a fixed target or the achievement of a 50% reduction LDL. So we decided we'd take a look at what the variability is. And what we found is that people on a high-dose statin, rosuvastatin 20 milligrams in Jupiter, had great variability in their percent reduction LDL. So while they averaged about 50% reduction, some only got 10, 20, 30% reductions. Others, however, got 70, 80, 90% reductions in LDL. And most importantly, those percent reductions tracked exactly with the event rates in the trial. So clearly lower was better, that's good, and greater percent reduction was better, that's good.
Well, let me interrupt for just a minute, because percent reduction doesn't always equate to lower, does it?
Well, it's always going to be lower, but it doesn't necessarily equate to below a certain target. So if you go from 150 to 75, that's a 50% reduction. If you go from 70 to 35, that's a 50% reduction. It turns out the percent reduction was a very good marker for did our patient really benefit from treatment. Now, the implication of this is a bit wider than that. Think about where we're going with PCSK9 inhibitors. These are powerful LDL lowering drugs. But if your LDL is already down 75, 80, 85%, it's hard to know whether there's going to be a lot of benefit focusing on LDL. Maybe you should focus elsewhere. On the other side of the coin, if it's only a 20% reduction, maybe that is the patient who needs to have a greater LDL reduction.
So, as a clinician, if I'm looking at a patient who has, let's pick a number, 35% reduction, and their LDL is somewhere around 50. In other words, they've got a pretty low LDL, but they started out at 75, and I just gave them something because they have a positive family history. Can I anticipate that they, even though they have a very low LDL, may still not do as well as if they had a 50% reduction?
Well, I think that may be correct. Now, the flip side is where the money's going to be, though. What about the people who've gotten a large percent reduction, but they're not below, say, 100 or below 70? I think that's where the rubber's going to hit the road. And the real question here is going to be, are we going to be calculating percent reduction and then thinking about, is that enough for my patient, or do we need to go further? And again, the Canadian European guidelines have gone that way. Interesting enough, Peter, the US guidelines have too, because our recommendation right now, even without a target, has been pick a moderate intensity statin, defined as a 30 to 50% reduction, or a high intensity statin, defined as a 50% reduction. So in a way, we're already there.
Okay, so after all that percent reduction versus levels and all that stuff, just for the folks out there that actually take care of patients, give me a two-sentence sort of summary. What does all this mean?
Well, what it really means is we need to be more aggressive, I think, in the first place. So in my clinic, as I'm sure in yours, most patients are getting high-dose statins. And we can't forget about the basics here. It's diet, exercise, smoking cessation. Primary prevention is still going to depend on good habits.
Thank you, Paul.